Good morning, everyone, and welcome to this week's Department of Medicine Grand Rounds. Before we get started, a few housekeeping points. Please make sure your mics are muted during the presentation. Also, we ask you that you hold your questions and comments till the end, at which time you may unmute yourself or put your questions in the chat box. Lastly, the CME credit on the screen will be displayed at the beginning and at the end of the presentation. Today's speaker is Dr. Sabahat Bokhari. Dr. Bokhari is a professor of medicine in the Division of Cardiovascular Disease and Hypertension and the program director of Advanced Cardiac Imaging Fellowship program at Rutgers Johnson Medical School, where he also serves as the director of Advanced Cardiac Imaging at the RWJ University Hospital and the director of Cardiac Amyloidosis and Cardiomyopathy Center. Dr. Bokhari completed his residency at the UMDNJ Robert Johnson Medical School and his cardiology and advanced cardiac imaging fellowships at New York Presbyterian Hospital and Columbia University Medical Center. Dr. Bokhari is an internationally recognized amyloidosis expert, as his research pioneered the development of technetium paraphase scanning, a non-invasive imaging modality used for the evaluation of cardiac amyloid. Throughout his professional career, Dr. Bokhari has received multiple awards and has level 3 certifications in nuclear cardiology, cardiac CT, and cardiac MRI. Please join us welcoming Dr. Bokhari.
Thank you so much for a kind introduction. So this is the text and the phone number for your CME, and I'm going to talk about cardiac amyloidosis, the great masquerader. These are my disclosures. So we will start with an overview of cardiac amyloidosis, but this talk is mostly focused on TTR amyloidosis. Then we're going to talk about the red flags, which should raise suspicion for this disease. And then we're going to talk about some non-invasive method of diagnosing this disease and also invasive methods of diagnosing this disease. And then lastly, we will discuss treatment for ATTR cardiomyopathy. So the journey for amyloidosis started about 170 years ago. Rudolf Virchow, which was considered as the father of pathology, first described the word amyloidosis, or coined this word amyloidosis, when he was looking at the liver histology on an autopsy sample. He saw this iodine deposits, and he thought that those were starch deposits, and he named it amyloidosis. Amyloidosis is a Greek word from amylon, which means starch, and idosis means resemblance. So that's how the name really started, with amyloidosis, which is a misnomer because, as we know, this is a protein disorder disease, not a starch disorder disease. Then the first time it was described clinically was by a Portuguese physician, Andrade, which first had a case report describing that familial amyloid polyneuropathy was caused by amyloidosis. Then a physician from Germany, Fredrickson, had a case series of patients who had cardiac involvement and described cardiac involvement with amyloidosis in 1962. There are 42 different proteins which causes amyloidosis. And out of those, 14 cause systemic amyloidosis, and 9 affects the heart. But the two most common amyloidosis which affects the heart are AL amyloidosis and ATTR amyloidosis. But 95% of all the amyloidosis is either AL or ATTR. And the other 5% are AA amyloidosis, apoprotein A1, heavy chain, and some other rare forms. So A stands for amyloid, L stands for light chain. Transthyretin amyloidosis is ATTR amyloidosis. Now, in AL amyloidosis, there are monoclonal plasma cells which overproduce immunoglobulins. And those immunoglobulin light chains then misfold and form amyloid fibers, which are insoluble fibers and get deposited in the extracellular space, of different organs and cause dysfunction of the organ. AL amyloidosis is considered a medical emergency. The reason is because once the heart is involved, if untreated, the median survival is less than 6 months. And also, for non-invasive diagnosis of TTR, you have to rule out AL amyloidosis first, because without, especially when we discuss the PYP imaging, we will address that issue. Transthyretin amyloidosis is, again, it's a transporter protein which transports thyroxine and retinol to different parts of the body, hence the name transthyretin amyloidosis. So this talk is focused on transthyretin amyloidosis or transthyretin amyloid cardiomyopathy. Now, transthyretin, this transporter protein, is produced by the liver, is secreted in the form of a tetramer. Once it's in the form of a tetramer, is stable. When the tetramer dissociates into dimers and monomers, then those misfold and form amyloid fibers, and these fibers aggregate and are deposited in the extracellular space of heart and nervous system and musculoskeletal system and cause dysfunction of the organs. Now, there are two etiologies for ATTR cardiac amyloidosis, or ATTR itself. And those etiologies, one is unknown idiopathic, but is associated with aging, and is called wild type ATTR. In old days, we used to call it senile amyloidosis, but now we have a better name, wild type. And the other cause is genetic mutation, which causes this ATTR amyloidosis. And that genetic mutation can present as predominantly polyneuropathy or mixed cardiomyopathy and polyneuropathy, or cardiomyopathy alone. So the three most common mutations which are present in US are V122I, which is also called African American mutation. And that's about 3.5% of African Americans carry that mutation. And about 5% of African Caribbean carry that mutation. 45% of all the hereditary ATTR is because of this mutation in US. And the second most common mutation is called T60A mutation, which is also called an Irish mutation. People who are from northwest of Ireland, from Donegal County, 1% of the population has that mutation. And about 20% of all the hereditary ATTR is by T60A mutation in US. The third most common mutation is V30M mutation, which is again divided into late onset and early onset mutation. Early onset mutation is also called Portuguese, Japanese, and Swedish mutation. And it predominantly presents with polyneuropathy in people under age 40 years of age. And the mixed phenotype, which is the most common phenotype worldwide, presents with the V30M late onset, presents with cardiomyopathy and polyneuropathy. Then 29 other rare mutations I'm not going to discuss today. So there are a total of 130 mutations which cause ATTR amyloidosis. But like we discussed, those are the three most common ones which are present in US. Now, this disease has a heterogeneous phenotype. It involves multiple systems, multiple organs. And because of that, it's the most underdiagnosed or misdiagnosed disease. So on an average, it takes about 3 years from the onset of symptoms for the patients to be diagnosed with this disease. And about 50% of the patients see a minimum of 3 different specialists before the diagnosis is made. And 17% of the patients see about 5 physicians prior to their diagnosis. And misdiagnosis is reported about 34 to 57% of patients with ATTR-CM, and about 75% of those patients are treated for their misdiagnosed condition. Now, there are only about 20,000 people in US who are currently being treated for this disease. But as we know that about 17% of HFpEF patients on autopsy had ATTR amyloidosis. And the other studies clinically in patients, about 13% of HFpEF patients have ATTR cardiac amyloidosis. Now, with this disease, there's poor survival if untreated from the time from the diagnosis. It's about 2.6 years for V122I mutation. And from other mutations, it goes up to 5.8 years. And for wild type, it's about 3.6 to 4.8 years. So it's really important to diagnose these diseases and start the treatment as early as possible, because the treatment works the best if started early. Now, especially for this disease, I think we have to, physicians have to act like a Sherlock Holmes. So as we know that Sir Arthur Conan Doyle was a physician, a British physician, who was very impressed from his professor, Dr. George Bell, who he thought that always looked for the disease as a detective and was able to diagnose these diseases. So I think especially for amyloidosis, we need to, for a cardiologist, we need to put an internist hat, because it involves multiple systems. And the only way we could really diagnose for this disease is if we look for it, and especially look for infiltration, which is hidden within the hypertrophy, and also look at the rhythm of the disease. This disease is rapidly progressive. If we look at the polyneuropathy of this disease, it's 10 times more rapidly progressive than diabetic polyneuropathy, and 8 times more rapidly progressive than any other polyneuropathy. So if we look at the incidence of this disease, we always thought it's a rare disease, but if we look at AL amyloidosis is a rare disease. There are about 4,000 new cases every year, and 70% of AL cardiac amyloidosis, AL amyloidosis have cardiac involvement. And they're about 10 per 1 million, so it's a rare disease. But if we look at the hereditary ATTR, like we discussed, about 3.5% of African Americans are carrier for V122I, and that's just one mutation for hereditary. And if you look at it, that comes to about 1.5 million African Americans carrying that mutation in the US. And then we know that the penetrance of this mutation is about 35%. So there are over 500,000 patients just with one mutation in the US. So this is not so rare. And then when we look at the ATTR wild type, we know that about 17% of the HFpEF patients have ATTR, and then about 10 to 25% of adults over 18 years, which we saw in autopsy data, had ATTR in their heart. So that comes to about 500K to 1 million patients. So again, not rare. And then when we look at it, how many patients in the US are currently being treated? It's less than 20,000. So what should raise the clinical suspicion for disease? So first is the clinical presentation, and then serum biomarkers, then ECG, and then echocardiogram, and then cardiac MRI. All these would raise clinical suspicion, but are not diagnostic for this disease. So for clinical presentation, like I said, it's a multi-system disease. So it involves most commonly cardiovascular system, nervous system, musculoskeletal system, renal, and ocular. In the cardiovascular system, the patients would present with exertional shortness of breath, exertional fatigue, lower extremity edema, which are all secondary to HFpEF. And the other thing which is important is that some of your patients who you've been treating for hypertension or heart failure suddenly cannot tolerate their blood pressure medications or their heart failure therapies. And if they have any LVH on their echo, think about this disease, because these patients are intolerant to vasodilators, intolerant to ACE inhibitor, ARB, and Entresto, and also beta blockers, because they have a very small fixed stroke volume, and they are relying on the heart rate increase not to get symptomatic. And if you see that there's a discordance between their EKG voltage and wall thickness on the echo, again, think about this disease. And on echo, that would show increased wall thickness. And then about 69% of these patients have atrial fibrillation. And about 22% of these patients have advanced AV blocks, which requires pacemaker. And also, the patients have patients who are going for TAVR. 16% of those patients have ATTR amyloidosis. So severe aortic stenosis, it's also in patients with severe aortic stenosis, think about this disease. On autonomic nervous system, it involves the small fibers, large fibers, and autonomic nervous system. So patients can present with tingling, numbness, pain in their toes and their hands and feet. And then it's usually their neuropathy is painful neuropathy. And then when the large fibers are involved, then they have difficulty walking, gait problems, and also painful, the painful extremities. And when autonomic nervous system gets involved, then they become socially isolated because they get chronic diarrhea, incontinence of urine, frequent UTIs, sexual dysfunction, and orthostatic intolerance. And for musculoskeletal, patients develop lumbar spinal stenosis, carpal tunnel, and bicipital tendon rupture. So these musculoskeletal involvement precedes cardiac involvement by 5 to 15 years. So if we start looking for this disease, especially in patients over age 50 who are going for bilateral carpal tunnel release surgery, you'll be able to diagnose these patients early prior to their cardiac involvement and start their treatment early. In renal, they get proteinuria, cardiorenal syndrome, and in ocular, they get vitreous opacities and glaucoma. So the top are all the symptoms which we just discussed for ATTR, and the lower figure is for AL. AL patients usually have macroglossia, have periorbital purpura, have shoulder pad sign, and also they have submandibular gland enlargement. So we looked at 151 patients with severe aortic stenosis who were going for TAVR surgery, and we found out that 24% of those patients, that is 16% of the patients, had ATTR wild type. And then when we looked at the gender differences, it was 22% males who were going for TAVR surgery had ATTR, and 4% females. So this is the criteria which most of the sites now use for screening patients who are going for TAVR, which patients you're going to screen with P/P. So anyone who has wall thickness of greater than 14 millimeter, does not have hypertension, and has severe AS, then if they have any one of the major criteria, which is the musculoskeletal one, which is carpal tunnel, ruptured bicipital tendon, spinal stenosis, or the serum biomarkers with NT-proBNP and troponin, or they have greater than 2 minor, which is diastolic dysfunction of greater than 2 grade, and AFib or advanced AV blocks, then those patients should be screened with PYP or DPD scan to look for amyloidosis. For serum biomarkers, we look at troponin levels. These patients have low-grade persistent troponin elevation. You'll see some patients, every time they come to ED, have mildly elevated troponins. And if they have LVH, think about this disease. They also have mildly elevated NT-proBNP levels. And once we see that, then we also look at pre-albumin level. Pre-albumin levels are basically looking at stable TTR levels. And then we also look at albumin level to look for modified BMI, which is a good prognostic marker if they have the disease. And same thing with EGFR, which is a good prognostic marker in these patients. But anytime you think about amyloidosis, you have to rule out AL amyloidosis. And for ruling out AL amyloidosis, you do immunofixation, serum and urine protein electrophoresis, not just SPEP and UPEP. It has to be with immunofixation because SPEP and UPEP are not sensitive enough to diagnose AL amyloidosis. And we also look at free light chain assays. So once those are normal, then you move ahead and look for ATTR, cardiac amyloidosis. Then when we look at ECG, so in the med school, we have been taught that when we see low voltage EKG, think about amyloidosis. Now, only about 20% of patients with ATTR amyloidosis have low voltage, and about 30% have LVH on their EKG. But in AL amyloidosis, 60% of the patients have low voltage. The thing which is more common is pseudo-infarct pattern in the anteroseptal and inferior leads. About 70% of the patients have that. And also, like we discussed earlier, 69% of the patients have atrial fibrillation. And also about 22% have advanced AV blocks. So always when we are looking at the EKG, we look for discordance between voltage and mass on echo. Then on echocardiogram is a workhorse for cardiology. And if we look at the left upper image, which is the apical fourth chamber, you can see the ventricle sizes are normal, but the walls are thick. And also you can see some speckle pattern on the walls, which is about 30% of the patients have speckle pattern, not all of those patients with amyloidosis. And their valves are thick, interatrial septum is thick, biatrial enlargement, they have small pericardial effusion. And when you look at the left lower image, which is a subcostal view, in that you can see the arrow pointing to the left atrial appendage, and there's the thrombus sitting in the left atrial appendage. 30% of the patients who are even in sinus rhythm or who are on DOACs or on anticoagulation with AFib have a thrombus in their atrial appendage. So these patients who have amyloidosis, we never cardiovert them, even if they have been on anticoagulation until or unless we do TEEs on these patients prior to cardioversion. And then we look at diastolic dysfunction. They have grade 2 or greater diastolic dysfunction. And then we look at tissue Dopplers. And in tissue Doppler, they have a 555 sign. Their S prime, E prime, and A prime are all less than 5 centimeters per second. Then we look at global longitudinal strain on these patients, which their apex is preserved in this disease. Their mid-wall and base is involved. So when we look at the bull's eye, it gives us the appearance of a cherry on top, because the red area which you see is the preserved apical function, and all the other mid and the basal is involved. But this is helpful in, or it raises suspicion for the disease, but it can also occur in some other conditions like hypertrophic cardiomyopathy, hypertension, aortic stenosis, and also stress-induced cardiomyopathy. The other thing which we look at is what we call septal reflectivity ratio. We look at the counts or the pixel intensity in the entire anterior septal wall, which on the parasternal long axis, and then we look at the same pixel intensity in the posterolateral wall, and then look at the ratio. Ratio greater than 1.5 is suggestive of ATTR cardiac amyloidosis. So these are the clues which I think are very helpful. We have asked our technologists who perform the echo to have that in front of them, and any patient who has any of these characteristics, they'll put it in the report that there is a suspicion of amyloidosis. So whoever is the reader then can put it in their final comments to consider amyloidosis, and if clinically indicated, to perform PYP scan. For cardiac MRI, again, raises clinical suspicion and is not diagnostic for this disease. So if we look at the top row, which gives us the same structural changes which we see with echo. So first one on the left upper figure is your vertical long axis. You can see LV walls are thick, cavity size is normal. And then when you look at the middle upper image, you can see that there is a little pericardial effusion, pleural effusions, and thickened walls. And the same thing on your short axis on the right upper image. But in addition to all these, which we see with echo, with the MRI, you look at the tissue characterization, which is with late gadolinium enhancement. So the image and the lower image on the lower left, you can see the arrows are pointing to the bright area. That's all late gadolinium enhancement. These patients have diffuse late gadolinium enhancement, and their blood pool is dark because most of the gadolinium is picked up by amyloid. And their myocardium also appears dark. And this disease is present on both LV, RV, and in the atria. So all this white area or lighter area which you see, which is pointed by arrows, is all late enhancement of gadolinium, which is mostly picked up by the amyloid. The other thing which we look at with MRI is looking at T1 images. And T1 images are, if you look at those red dots in that green area, that they're more red means there's the T1 is higher on the T1 map. So, and when we're looking at T1, which is basically looking at mostly fibrosis, and it's higher with AL and ATTR amyloidosis as compared to your normal controls or in patients with hypertrophic cardiomyopathy. Then we use the T1 pre-contrast and post-contrast to measure what we call extracellular volume. So if there is more deposition of amyloid, because amyloid is deposited in the extracellular space, the extracellular space is increased, extracellular volume is increased. So in patients with AL and ATTR amyloidosis, their extracellular volumes are higher. And if the extracellular volume is greater than 0.45, that is also a poor prognostic marker. So now we'll move to diagnosing this disease. So for diagnosing this disease, prior to 2013, the only way we could diagnose this disease was with endomyocardial biopsy. Now, then since 2013, we have started doing it non-invasively with the bone-seeking tracers. So the three common bone-seeking tracers which are used for diagnosing this disease are PYP, which is pyrophosphate, HMDP, and DPD. MDP does not work for amyloidosis because there's a very minimal uptake in the myocardium. And same thing with the sodium fluoride, which is a PET tracer, also is not that good for diagnosing this disease. Then there are some newer tracers, which are PET tracers. Those are not clinically approved yet, so I'm not going to go in detail. And there are some new in the pipeline, which are also PET tracer and SPECT tracer. And then there is a MIBG tracer, which is used mostly for familial amyloid polyneuropathy. So I'm not going to go in detail on that. So if we look at the tracer, which is now commonly used to diagnose this disease in US and most of the world, is a PYP scan. And now PYP scan was first approved by FDA in 1974 for bone imaging. And then again in 1970s, it got approved for identification of myocardial infarction. That was prior to CPKMBs and prior to troponins. The only way we could diagnose acute MI was doing a PYP scan. So in early 80s, there were a couple of case reports in which they said in amyloid patient, there was the heart was lighting up. And then there was a case series published by Rodney Falk from BU at that time. Now he's at Brigham. And he said that this was a useless test because it was about 30% sensitive in picking up amyloidosis. But at that time, we were not distinguishing between AL and ATTR amyloid, and that was prior to endomyocardial biopsy data and mass spectroscopy, and prior to looking at immunofixation. So then in 2002, Pewley from Germany reported an 8-patient case series, the patients who had ATTR familial amyloid polyneuropathy, and he saw that 3 of those patients in which their DPD scan, these are the whole body scans. They do a whole body scans with DPD. And so the DPD scan lit up in 3 patients, and those 3 patients had cardiomyopathy and arrhythmias. So he suggested that this might be, DPD might be a good test to look for this disease in patients. And then Perugini and Rapizzi's group from Italy in 2005 looked at 10 patients with AL, 15 patients with TTR amyloidosis, and 10 controls, and came back and said that it was 100% sensitive and 100% specific, this DPD scan, whole body scan, in diagnosing ATTR amyloidosis and differentiating it from AL cardiac amyloidosis. So at that time, I was at Columbia, and one of my friend and colleague, Matt Morer, asked me if he could do DPD imaging to diagnose this disease in the US. So we wrote to FDA. FDA said it's not approved and we cannot use DPD imaging. So we looked at the isotope and saw which one was closest to DPD. And we found that PYP had the closest chemical structure to DPD, and PYP was readily available in US for blood pool imaging and also for bone imaging, and was approved for detection of MI. So we wanted to design a protocol which can easily be done in US. As we know that 90% of the SPECT cameras used in US are in cardiology offices, and they are not capable of doing a whole body imaging. So we wanted to design a protocol which would be just the chest protocol, simple protocol, low cost, and would not require a nuclear medicine physician to read it, and it can be easily read by a cardiologist. So the top protocol is the whole body scan, which is done in Europe. And the bottom one is the one which we came up with in this isotope PYP. And it was a shorter protocol. You inject after 1 hour. If it's negative, patient is done after 5 minutes of scan. If it's positive, it's about 18 to 20 minutes of scan, and you have your answer. And if about less than 10% of the patients will have some blood pool, and those you'll repeat the scan in 3 hours. So it's less radiation, shorter protocols, not the whole body scan, can easily be done in any outpatient facility in which the cardiologists have those SPECT cameras. And we made it a very easy way to read it. On the left side, you'll see there's no uptake of in the heart. And on the right side, you can see the heart lights up, the LV and the RV. So we gave it a score of 0 is absent counts, 1 is mild uptake, less than ribs, 2 is equal to ribs, and 3 is greater than ribs. If the score was 2 or greater, it was positive for TTR amyloidosis. And then, because when we looked at that, we asked 3 different readers to read it, and we found that there was some inter-observer and intra-observer variability among the score of 1 and 2. So to have a better quantitative method, we came up with this heart to contralateral ratio, in which we draw the ROI on the LV and just mirror image copy that ROI on the right side, away from the right atrium and above the diaphragm, and looked at the mean counts. And what we found is on the right figure, which you can see that if the heart to contralateral ratio was greater than 1.5 at 1 hour, the sensitivity was 97%. There was only one outlier in the patient. There were about 45 patients, and specificity was 100%. So after that, a lot of sites started doing PYP imaging, and we also, in PYP imaging, we stress that you should do SPECT imaging if there is any uptake to differentiate between blood pool and the myocardial uptake. And if you have a SPECT CT camera, that's preferred because that really differentiates the myocardial uptake from the blood pool, which you can see over here. Sometimes if you have blood pool in the LV and RV, it might look like as if there is uptake in the myocardium, which you can see on the left figure right over here. So it looks like that this is LV uptake, but this is just blood pool in the RV and LV. So anytime you have a SPECT scan without the SPECT CT, if the apex is missing, think about blood pool, because that could be just RV and LV blood pool. So if you have SPECT CT, which is preferred, then you can see it much better. So if your clinical suspicion is high, and even if the PYP scan is normal or is negative, you should move ahead with endomyocardial biopsy. So I would say that about 5% of the patients would end up needing the endomyocardial biopsy, but 95% of the patients you'd be able to diagnose with PYP scan non-invasively. And there, we don't do abdominal fat pad biopsy or bone marrow biopsy because the yield is really low. It's about 15% for ATTR wild type, and is about, again, 34% with bone marrow biopsy. So these are not good tests to diagnose ATTR cardiac amyloidosis, are better tests for AL amyloidosis. So then in 2016, we had 9 centers from worldwide, and we put our data together, which came to about 857 biopsy-proven amyloid patients, and with 360 with non-amyloid cardiomyopathy. And then we looked at the sensitivity and specificity of these PYP imaging and found that it was more than 99% sensitive. Specificity was 86% if we had not ruled out AL amyloidosis, because about 15% of AL amyloidosis also lights up with PYP scan. So it's very important to rule out AL because it's a medical emergency. Once the heart is involved, the median survival is less than 6 months. And also because you cannot diagnose ATTR without ruling out AL amyloidosis. So ATTR you only rule out in the context of negative AL amyloidosis testing. So we first do the monoclonal protein with the immunofixation, and also look at free light chain assays. If those are positive, you send the patient to a hematologist. And if those are negative, then you're going to do your PYP scan over here. And then if the PYP scan is positive, then we move ahead and do the genetic testing to look at the etiology of ATTR cardiac amyloidosis, whether it's hereditary or it's the wild type amyloidosis. It's very important that we do pre-genetic counseling before we do the genetic testing on a patient. And we should be aware of the penetrance of each mutation so that we can give the patients better information. The reason it's important to do pre-genetic counseling is because if their test comes back positive, that can affect their life insurance, their disability insurance, and their long-term care insurance. So in summary, we recommend planar imaging, heart to contralateral ratio, and SPECT imaging for technetium PYP amyloid scans. If you have SPECT CT available, that's preferred because that reduces the false positive rates. And PYP is considered positive for TTR cardiac amyloidosis after AL has been ruled out. And then again, genetic testing is recommended to identify the cause of ATTR. And if your PYP scan is negative and there are strong clinical or imaging clues for cardiac amyloidosis, then consider endomyocardial biopsy. Now, since PYP is being used now readily at most of the places and most of the private offices, we have seen that there's a lot of false positive results. 10% of the patients which I see in our amyloid center, I take them off of treatment because they have been falsely diagnosed with cardiac amyloidosis. And that's because of lack of expertise in reading the scans, especially there's someone who's reading the scans is not experienced with the PYP imaging. And also because if they're screening a lot of patients with low pretest probability, the numbers which we saw with 100% sensitive and 100% specific were all from amyloid centers where they had good expertise for reading these scans. And also now we are screening the disease early. So that's also another reason for having some false positive and false negative results. For treatment of ATTR cardiac amyloidosis, we treat it at 3 levels. One is at the level of the liver, in which we call it silencers, which we use for the treatment. There are 4 silencers which are approved by FDA. One is called patisiran, other one is called inotersen, and the third one is called vutrisiran, and the fourth one is called eplontersen. Now, the earlier 2, which is patisiran and inotersen, were the earlier precursors of, I'll say, vutrisiran and eplontersen. So the ones which are most commonly used now are vutrisiran and eplontersen because it's easier to use, have less adverse effects. So what they do is that they act at the liver level, and they basically are conjugated by N-acetylgalactosamine, and that enhances its uptake into the hepatocyte. And in hepatocytes, they degrade the messenger TTR RNA, which is responsible for production of TTR protein. So they knock down the production of TTR protein by over 80%. And so when there's less TTR protein, there'll be less dissociation of a tetramer and less misfolding and less formation of amyloid fibers. The second step where we treat these patients is where we stabilize the TTR molecule or the TTR protein. And so when it's in a form of a tetramer is stable, when it dissociates into monomer, then those misfold and form amyloid fibers. So to stabilize the tetramer, there are 2 stabilizers which are approved. One is called, there's only one stabilizer which is approved right now, which is tafamidis. And the other one will hopefully get the approval next month. It was already applied to FDA, and next month they are going to hear from the FDA. And that is acoramidis. And these 2 are called selective TTR stabilizers. And then there is one which is non-selective, which is the NSAID, which is diflunisal, which is used off-label in some of the patients. The third one, which are right now in the clinical trials, mostly in phase 2 and clinical trials, and some of them have gone into phase 3, is what we call reabsorbers. Those are the ones which reabsorb the amyloid fibers which are already deposited. And those are by monoclonal proteins, so monoclonal antibodies, and also some macrophages which are primed to phagocytize amyloid fibers. And off-label use of doxycycline and also ECGC, which is present in green tea, that breaks down the amyloid fibers. Now, the silencers which, so currently silencers are only approved for polyneuropathy. Stabilizers are approved for cardiomyopathy. But the recent results from Helios B trial was excellent results for vutrisiran in cardiomyopathy, and they have submitted their NDA to FDA for approval in cardiomyopathy. So when we look at the heart failure treatments, again, these patients cannot tolerate ARNIs, ACE inhibitors, ARBs, and also beta blocker can worsen their symptoms. The other medications which are helpful are spironolactone and Farxiga or SGLT2 inhibitors are helpful for these patients. And also the diuretics, the ones which have better bioavailability like torsemide and Bumex are better tolerated for these patients as compared to furosemide. And then heart transplant in selected advanced patients, and then some patients you'd consider palliative care. For arrhythmias, these patients, once you put a pacemaker, if they need a pacemaker, they're dependent on their pacemaker. So we prefer doing a CRT for these patients whenever they need a pacemaker. And like I discussed earlier, if they have AFib, they should be cardioverted after the TEE, because even with anticoagulation, these patients have, a large majority of these patients have a thrombus there. And for treatment, currently the only stabilizer approved for cardiomyopathy is tafamidis, which hopefully we'll have another one next month. And within 6 months, we'll also have a silencer approved for cardiomyopathy. And for the hereditary one, for polyneuropathy, silencers are approved. 4 silencers are approved to treat polyneuropathy. And for, again, hereditary cardiomyopathy is tafamidis, which is a stabilizer which is approved. For AL amyloidosis, these are treated by a hematologist. And so for AL amyloidosis patients, their primary provider is the hematologist. For TTR amyloidosis patients, their primary providers are cardiologists. So the elephant in the room is the price. If we look at tafamidis, now the price is over $250,000 per year for treatment. So each pill costs over $600, and they have to take 1 pill a day. And the TREC trial showed excellent, about 30% reduction in mortality, 32% reduction in hospitalization for these patients. And it was pretty safe. The adverse effects were similar to placebo, but the price is a problem for these patients as compared to that non-selective one, which is available, but it's used off-label. It costs about $60 per month, but the problem is it's an NSAID. And like we discussed, 69% of these patients have AFib, are already on a blood thinner, so there's a risk of bleeding. Also, they have heart failure, so fluid retention, renal dysfunction. So very few patients can take diflunisal, but if they can, that's in some patients, we still use that. Then if we look at the silencers, again, they are over $450,000 for the top one, patisiran. Now the price is that, and the new one, which is used now, vutrisiran, that's again over $500,000 a year. Same thing with inotersen, and the new one, which is eplontersen, can cost over $500,000 a year for these patients. So again, we have learned a lot with amyloidosis. But every time, we know more about this, we still find out we still don't know a lot about this disease. Again, why the phenotype is so heterogeneous, and why cardiac involvement is prevalent in men, especially in wild type. In wild type, about 80 to 90% of the patients are white males. And why, despite a gene mutation which is present from birth, does the disease appear after 30 to 40 years? And why this disease, especially the wild type, is a disease of elderly? And what is the cause for this disease? Are there certain triggers which cause this disease? And should we treat asymptomatic carriers of ATTR mutation? And again, what stage you're going to withhold the treatment for these patients? Can advanced heart failure be an exclusion criteria for treatment? Can age be an exclusion criteria for treatment? How to assess progression of disease or response to treatment? And should we combine different treatments? All these questions need to be answered. And what is the mechanism, how this PYP uptake in cardiac amyloidosis is? So we still don't know the mechanism. We know we can diagnose this disease. Don't know how does it really work, and why there's a mixed type uptake in TTR type B cardiac amyloidosis. In type B, you cannot, some of the patients are negative with P/P scan. Why there is not significant uptake in AL cardiac amyloidosis, why it's only TTR. And when should we screen asymptomatic carriers of ATTR mutation with P/P imaging? And can we assess progression of disease with P/P imaging? All these questions need to be answered. Thank you for listening, and this is your text.
Dr. Bokhari, thank you for a great presentation discussion on amyloid, cardiac amyloid, and really bringing to the table all that we know, and as you noted at the end, some things that we don't know, and really to put in perspective AL and ATTR and the types of ATTR and the diagnostic workup and treatment. So again, thank you for a wonderful presentation. We do have some time for some questions. I'll encourage folks to either put things in the chat box or raise your hand or speak up. While waiting for that, let me just pick up on something that you just, I think, noted. In the folks, who have ATTR, you've identified one of the common polymorphisms. Do you recommend testing of offspring? What are you doing with that?
Right. So patients who have a TTR mutation, say if they have E122I, so their siblings are the first ones which we would like to do the genetic testing on. And then their children who are, at least a little older. I would say what I usually suggest to patients is that 10 years prior to the onset of disease for that mutation to start the screening for this disease. And so to do genetic testing. That way, we can find out which patients need to be monitored closely to see when they develop the disease so we can start the treatment early.
Yeah, let me just have a quick follow-up on that. So when those kids, let's say, who you test and you see are positive, what then screening do you do to try and catch the disease as early as you would like to start treatment?
That's an excellent question. So what we do is if they are 40 to 50 years of age, we are going to do their serum biomarkers. We would look at NT-proBNP, troponin, and CMP, and prealbumin. If any one of those would suggest that the patient might have the disease, that means if their prealbumin is low, or if their troponin is high or NT-proBNP is high, then we are going to consider doing a PYP scan. We do echo every 3 years for these patients, which is from 40 to age 50. After age 50, we do serum biomarkers every year, and echo every year, and PYP scan every other year.
That's great. Thank you for that. I really appreciate that very much. We have a question in the chat, Dr. Budnick, about the green tea that I think probably caught people's attention. would you recommend green tea for treatment or prevention in people who are at increased risk? And if so, how much green tea?
Right. No, that's an excellent question. So the results from phase 2 trial for ECGC, which is present in green tea, are excellent, right? So what I tell my patients is if they can find decaffeinated green tea, because most of these patients have AFib, if they can find decaffeinated green tea, they can drink 3 to 4 cups a day. That will be good, but this is just hand waving from my side. There's no data, but I tell all my patients to that, because the ECGC, which is used in trials, is pretty high quantity ECGC, which for that you need 20 cups of green tea a day. So but at least having a little bit is not going to hurt them.
Thanks so much. Other questions or comments, or please raise your hand or in the chat or speak up. Maybe while we're waiting, just to ask you, it is really interesting that in the TAVR patients, as you noted, about 16% of the patients really do have underlying amyloid, but this differential between the men and the women, 22% of the men and only 4% of the women. Yeah, what do you think about that? You alluded to it also in your list of questions as well.
Right. So as we know that for wild type, which is the most common type of TTR amyloidosis, or most common type of any amyloidosis in the heart, about 80 to 90% people are male for that. So, and most of the wild type is in older patients because it starts in their late 60s or early 70s. So, so 22% of the patients who are going for TAVR, especially male patients, have ATTR, and that's not including the patients who have LVH. If you include, these were just journal patients who are going for that. If you include LVH of greater than 14 millimeter in the same group, then it goes to 34%. So 34% of all the male patients going for TAVR have. So that means 1 in every 3 patients. So, and, you know, even over here at our center, we do not screen for the TAVR patients with P/P scans. So I think it's very important that we do that. And the other area, which is also very important, is patients who are going for carpal tunnel release surgery. So as we know that 60% of the patients who have amyloidosis have bilateral carpal tunnel. And the reason carpal tunnel is important is because you can diagnose this disease before cardiac involvement, and at least 5 to 15 years prior to that. 10% of patients over 60 years of age who are going for carpal tunnel release surgery have positive TTR amyloidosis in their specimen. So we can diagnose these patients quite early. So if we can ask the hand surgeons that in all the patients in which they are doing open release for carpal tunnel who are over age 60 to just send the specimen for biopsy.
Yeah, and I really appreciate your mentioning that again, especially certainly here in our community here in Europe with a large African-American population. As you noted, 3.5% of the African Americans have one of the well-recognized polymorphisms. So yeah, and the presentation with the musculoskeletal problems is really super important for, I think, certainly all of us to really remember that. So thank you for noting that.
Dr. Bokhari, great talk. You know, while we don't know why there's deposition or why PYP studies are positive, you know, once that's already there, you could argue maybe the damage is done. In patients who are genetically positive, how could we, and we have gene silencers available, how can we identify people who may be at risk and maybe starting gene silencers earlier to prevent the actual deposition in the myocardium?
Right, so that's an excellent question, Alfonso. So in the biggest thing is whether we can reduce the production of TTR or we can stabilize the TTR, you know, so that it won't dissociate. We can, for silencers which we use, Those are, again, very expensive, over $500,000 a year. And for these younger patients, if we put them on a silencer, they'll be on a silencer for over, say, if they're going to develop any myocardial deposition after 10 years. So it's about, close to $7-8 million per patient, and in those who will develop the deposition in their myocardium. So what we do currently for these younger patients, and also no payer is going to pay for that. So payers are not going to pay for those patients, whether when they know that they have not even developed the disease. But what we do for that is that we put these patients, because these are younger patients little, and they have not developed the disease yet. They don't have heart failure symptoms. They don't have that much renal issues. They are not in AFib because their myocardium is not involved. We put them on diflunisal. So all these the carriers, and this diflunisal, which is a non-selective, is cheap medication. They can tolerate it well. And so that way we know that if we are stabilizing that, so that means it's not going to form amyloid fibers. It's not going to form monomers, which are going to misfold and form amyloid fibers. So that way we can prevent some deposition into the myocardium.
Dr. Bokhari, thank you. On that note, I think our time is up for this morning. I do want to thank you for again, a wonderful presentation, really terrific, and really appreciate it very, very much. I want to thank everybody for joining this morning for this grand rounds, and wish everybody a great rest of the day. Thanks very much.
Thank you so much. Thank you for inviting.